Thank you, and thank you, Chair, and all for having me here. My name is Dr. Michael Laidlaw. I'm an endocrinologist practicing in Rockland, California for about the last 15 years in private practice. I've been looking into this area deeply for about the last 5 years and have written papers and have been an expert witness and given talks on this subject throughout that time. So I'd like to go through with you some of the medical consequences from this treatment. Being in endocrinology, we study glands and hormones. When hormone levels are very high, they can cause problems. We try to bring them back into balance. If hormone levels are very low, that causes various problems, and we try to bring those into balance. And what you'll see here is what they're doing with hormones is putting young people way out of balance. Just for some definitions, gender identity is the internal feeling of being a boy or a girl or some variation. Gender dysphoria is the discomfort that results from having a perceived gender that mismatched with the person's body, leads to significant distress and impairment lasting at least 6 months. Majority of these children, depending on what study you look at, but still the majority will grow out of this by adulthood, some 50 to 98%, depends where you're looking. So anytime we undergo any sort of treatment for a condition, we want to have a definite diagnosis. So if I want to treat diabetes, I want to make sure someone has a really high blood sugar. If we're going to treat cancer, we want a biopsy to prove that there's a cancer there to treat. How can we prove the gender identity? Can you find it on a scan, like a CT scan, or a brain biopsy or genetic testing? The answer is none of the above. There is no definite physical evidence of a gender identity, and therefore many kids will grow out of this and will be harmed if they undergo the treatments I'll describe. A bit of basic biology. There's only 2 human sexes. You can verify this by thinking of your own fertilized ovum. When you developed, there was a male sperm and a female egg that led to development. This proceeds on in embryology, where males and females are initially have similar tubules, but then there's a divergence, a split, with the males developing male-specific organs on one side and the females on the other. This happens very early in embryology, and the bridge cannot be crossed thereafter. There's 4 stages to gender affirmative therapy: social transition, or wearing clothes stereotypical of the opposite sex, or adopting mannerisms perhaps. Puberty blockers, which Dr. Biggs described very well, cross-sex hormones or opposite-sex hormones, and surgical modifications. Just to have a look at one good long-term study of Sweden, they looked at 30 years of data for 324 individuals who had hormones and completed surgery for transition. And over time, you can see here at year 0 to 30 years, survival rates dropped dramatically after 10 years for those who had transitioned. They also found that they had 3 times the rate of all-cause mortality and 3 times the rate of inpatient psychiatric care, and 19 times the rate of completed suicide compared to the population of Sweden. This is just showing what Dr. Biggs had described. Puberty blockers, this is the pituitary here, and these are the testes. They stop the normal communication between these organs, resulting in low testosterone for males, low estrogen for females. These are the normal, what we call Tanner stages of puberty, from early development to final adult development in males and females. And what the Endocrine Society is proposing is to block this very early on, Tanner stage 2. Why is this important? Because fertility is established around Tanner stage 4. So if they're blocked with puberty blockers and then take hormones and have surgeries, they will have infertility, and if they have surgical removal of their organs, they will be obviously sterilized. To move on to cross-sex hormones or opposite-sex hormones, to give you an idea, this is showing female adult testosterone levels. It's in a fairly narrow range from 10 to 50. Females do have some amount of testosterone, which we associate with males, but there is some smaller amount in females. In a common endocrine condition that I see, polycystic ovarian syndrome, it will be higher, say from the 40 to 150 range. With rare endocrine tumors, this will be much higher, say from 150 to 1,000. And these are dangerous tumors, which generally have to have surgery or other treatments. What are they proposing for hormones for this treatment is to bring levels to 300 to 1,000 level, which is on the order of these dangerous tumors that I described, and is some 6 to 100 times higher than endogenous female levels. What are the consequences on the body for that? To stay with females here, but females and males both have an increased risk of myocardial infarction and death due to cardiovascular disease, they found. Females will develop very high red blood cell counts, which is also a risk for heart disease. They can develop liver dysfunction, high blood pressure, various cancer risks of the ovary and breasts, hirsutism, which is hair growth all over the body in different portions, particularly the face and abdomen, a deepening of the voice, and both of those are permanent changes, sexual dysfunction and infertility. For males taking estrogen, again, these are very high doses of estrogen. There's a 5 times increased risk of thromboembolism or deadly blood clots. Gallstones, high triglycerides are possibilities. Breast cancer risk has been increased by 46 times, and also sexual dysfunction and infertility. What about going back to testosterone? High doses of testosterone have, in terms of psychological effects, have mainly been studied with anabolic steroid abuse. And what they found in those studies is that some 23% of subjects using these high doses met criteria for major mood syndromes such as mania or major depression, and even 8% or so developed psychotic symptoms. So it's a problem for the body and a problem for the mind to have these hormones so grossly out of the normal range. To move on to surgeries, referred to earlier as top surgery or mastectomy. This is a person who's natal female, born female. You can see the male growth pattern on the face we call hirsutism, and in the abdomen, and a surgical procedure has been done to remove the breasts. Complications from that, of course, the person will lose the ability to breastfeed. The woman will lose the ability to breastfeed. There can be significant scarring of 7 to 10 inches that can widen and cause problems, can cause pain, loss of normal nipple sensation, and difficulties with wound healing are possible complications. Just to emphasize, here's another study, 2018, I believe, showing how young patients around the country are getting the surgery. There were 2 13-year-olds who had mastectomies, 5 14-year-olds. You can see 15 and 16-year-olds. Professor Biggs had described the surgery. I won't go too much into it, but again, the problem with stopping a male at Tanner stage 2 is that they'll have a very undeveloped penis and scrotum area. Therefore, when the cavity is produced where the penis is inverted inside, there's not enough tissue, so a portion of colon needs to be attached to it, or there are other procedures which increase your risk and risk for multiple surgeries. Complications can include strictures of the urethra, infection, prolapse, fistulas, injury to the sensory nerves, with partial or complete loss of erotic sensation. This is showing the phalloplasty, or the creation of a pseudo penis. A swath of tissue is taken from the forearm or thigh and rolled into the pseudo penis. This obviously can have very high rates of complication, as you might imagine. One study showed 76% had urethra fistulas or urethral strictures. Other complications could include infections like peritonitis. You'll obviously have large scarring to the forearm or thigh, possible injury to the sensory nerves. So what is the basis for this type of treatment? Who's making these rules or guidelines and such? The Endocrine Society, which I belong to and is otherwise does very good work, except in this area, produced clinical practice guidelines in 2017. I think you should know that 9 out of 10 of the persons who created these guidelines belong to the organization called WPATH, which is an advocacy group and is not a medical organization, though it has some medical doctors. So it's a very biased sample of physicians and others who created this document. They have in their disclaimer very clearly that this does not establish a standard of care. So if you hear it's a standard of care, they even said it isn't the standard of care. If you look at the grading of evidence, it's either low, very low quality, or there's no evidence for what they're doing. Now, the WPATH, which I just talked about, is an international organization. They create standards of care which really exist within their organization. It doesn't apply to anyone else and shouldn't apply to anyone else. And with this recent set, they actually lowered or remove the age minimums for surgery. So any of the things that I described and the other doctors described could be done at any age, which is obviously extremely dangerous, and children cannot consent to these procedures. They also removed all guidelines for minimum age of opposite sex hormones, in contradiction to the recommendation of their own expert consensus. So this is an extreme document, presents a grave danger to minors and should not be followed by any healthcare person in Florida or anywhere else, in my opinion. How can we help these kids? Well, they have high rates. Dr. Levine will, I'm sure, talk about comorbid psychological illnesses. These need to be treated and discovered. Perhaps they had physical, sexual abuse or autism, problems with in the marriages or family problems due to divorce. These things need to be identified and properly treated by qualified psychologists, psychiatrists, counselors, and others who don't follow the WPATH model, individual counseling, family counseling. Just to emphasize, it's not a standard of care. We don't have the technology to make a male into a female or vice versa. Kids would not understand this. We don't know long-term outcomes, and what we do know for adults is not good. Medications are being used off-label, experimentally, and at high doses without proper FDA risk assessment profiles. Evidence quality is very low, as we said, and desisters and detransitioners have been ignored, though there are some studies showing the problems that they've had. Thank you very much for allowing me to present.
Thank you. I very much appreciate it. And again, look forward to questions. That was an excellent presentation. We're going to continue with our medical professionals. We're sort of hearing them all up front. We're now going to hear from Dr. Levine, who is the clinical professor of psychiatry at Case Western Reserve University, so he is not as far away. He's also joining us remotely. Dr. Levine, you are recognized.
Thank you very much. I plan to emphasize 13 ideas that I have found in the literature written by those who affirm care for children and adolescents and adults for transgender phenomenon. Each one of these 13 points, I believe, is scientifically untrue. Nonetheless, they are firmly believed, and when they are countered in meetings, when they're confronted in meetings, it produces a passionate outcry that it isn't true. But as far as I can see, these 13 ideas are not scientifically verifiable and are clinically, apparently incorrect. Nonetheless, affirmative care doctors assert them in their writings and in their speeches repeatedly. And so, having eavesdropped on this literature for all these years, I feel very strongly that each of these points can be defended as correct. That is, none of them are correct. And before I give you these 13, I want to raise that one way of considering this big question of trans care for youth is whether this is an example of therapeutic advance to help afflicted human beings, or whether this is yet another medical misadventure. That in medicine we have a history of many medical misadventures. Most recently, and most damaging is the opioid epidemic, where we began prescribing in medicine opioids liberally without scientific demonstration as to its use and its utility and its harms. And now every state in the United States and elsewhere is suffering from premature death due to opioid abuse. So here are the 13 things that are not true in my view. A trans identity, once established, is immutable, unchangeable, unchanging. This is clearly not true. Second, trans identities are primarily caused by prenatal biologic forces. That is, the justification of the treatment is we're just correcting some biologic, embryologic mistake. And third, sexual orientation is entirely independent of gender identity. Sexual orientation is a bias that all of us have towards for romantic and sexual purposes for members of a class of males or females. And in the standards of care from WPATH, it's been asserted that they're entirely separate. But when you watch the child develop from a childhood to puberty to middle adolescence, you often see that the first manifestation of gender dysphoria, before gender dysphoria shows up, it is that I am attracted to members of the same sex. And you watch the evolution throughout adolescence of orientation, and you quickly see that they are not entirely separate phenomenon like the advocates say they are. And the fourth idea that is not true is that no form of gender identity is an abnormality, and no form of gender identity is a symptomatic reflection of some other problem. This is not a psychologically tenable concept, but it is asserted all the time, and you can read it in the standards of care. Fifth, gender dysphoria is a serious medical condition, and it requires medical intervention only if the patient wants it. So there is some inherent paradox in that idea, right? It's a serious medical condition that implies that we should treat it. We should treat it, but we should only treat it if the patient wants it. 6, the associated emotional problems are primarily due to living in a discriminatory world, even though many of the children who are diagnosed with gender dysphoria previously have been diagnosed with other problems. 7, no effective alternative approaches to affirmative care exist. This is the only thing that will save your child, we tell parents, you see. And many of the practitioners actually believe there are no alternate approaches, but Dr. Laidlaw just told us about an alternate psychiatric approach. 8, attempts to provide psychotherapy are unethical versions of conversion therapy and should be outlawed. You see, any attempt to help the child and the family is called conversion therapy, and people are urging that to be outlawed in various jurisdictions. 9, affirmative care lastingly improves mental health and social function. This is the justification for the treatment, even though we don't have studies that demonstrate that. We don't have long-term studies at all that demonstrate that. And we have many studies that indicate, and you've seen slides of the death rates, and a recent study has reaffirmed the elevated death rates of transsexual adults. So the idea that this improves mental health is uncertain at best. 10, affirmative care reduces the rates of suicidal ideation and prevents suicide. This is the most powerful coercive untruth that parents of teenagers are told. Would you rather have your child visit your child in the cemetery or have a trans child? And many people, including one of our panelists today, have demonstrated the lack of veracity of that assumption. When we look at the Swedish studies, the females who underwent sex reassignment surgery had, I think, 40 times the suicide rate, and the average suicide rate that was quoted was 19 times, but because the male's suicide rate was a little less than 19. So we realize that we are exposing people to the great risk of suicide in the long run. And when we don't have follow-up studies of the youth, you see, we need to be informing parents about what we do know about the long-term outcomes, which is not happening at all. And 11th idea is that young teens know best what will make them happy in the future. I hear that all the time, because this is their genuine, true self. Not true. They don't know what's best for them necessarily. And 12, meeting diagnostic criteria for gender dysphoria predicts a good outcome to affirmative care. That's not true either. And finally, regret and detransition are rare among these patients. as the last 2 years have begun to show, detransition is increasingly recognized. Regret is, when people assert that regret is rare, it's because they're defining regret as telling their original therapist that they wish they didn't undergo this, or asking to have their body rechanged back to their original form, which is a very limited concept of what regret represents. So these 13 ideas, I think, stand as a monument to the assertions that affirmative care, the science of affirmative care, has already established its superiority and its benefit. If ideas that underpin intervention are not true, are not correct, how can we trust the intervention itself? I think that's all I wanted to say to you today, and I'm happy to answer any questions in the future.